All right, so today we're going to talk about really, for the most part, the tough part about Lyme disease. So just to get it on the table, you guys are obviously pediatricians. Childhood Lyme, adult Lyme, the guidelines are pretty much the same. We do about the same things, except for we don't use doxy when the kiddies are young. But besides that, I think some of the presentations are actually a little different as far as when the kids come to presentation, when adults do. But that's really not the interesting part. So I think age really doesn't matter at this point. And it's a lot of the controversy is about sort of the chronic Lyme disease or post-Lyme syndrome, lots of various names. I think in some ways the names maybe matter. And we'll talk about that a little bit. So I'm not going to be able to, unfortunately, by the end of this talk, you're not going to know exactly what to do and how to manage these patients because I don't. Having done this for 20 years, I don't know. And that's one of the problems. So it's easy for me to say, antibiotics don't work long time. I don't want to give it to you. I'm worried about resistance, side effects, and things like that. But these patients don't leave happy. They don't leave satisfied. They don't leave feeling better. So, I think the issue, and obviously the other issue is that the patients on long-term antibiotics, they're in the same boat, right? They're not feeling well. Otherwise, they wouldn't be coming back to me, or they wouldn't be trying to find a Lyme designated specialist. So there's a lot of unrest. That won't be answered by this talk. But we'll start with something easy. Which of the following cases, 4 cases, are not consistent with erythema migrans? Okay? Here's the first case. 57-year-old male, lives in South Shore, spends summers outdoors, notes a small red dot on the left upper thigh, increases in size, initially surrounded by a white halo, followed by a red halo. Center becomes necrotic, mild discomfort, febrile on admission, temperature of 103, and you can see there. Not very painful, and look pretty impressive. Okay. Case 2, patient notes asymptomatic rash after getting out of the shower in July. You can sort of see it. I don't know if we need to turn the lights down, but you can see it's somewhat elliptical, a little bit of a darker center, fading at the outside. 3, middle-aged female with low-grade fevers, bilateral knee pain and rash. Okay? Homogeneous erythema, right? No bullseye there. And then child, expanding elliptical rash on the back, soreness in the knees in May. It's not a circle. Is there a bullseye there? There's a little bit of one, right? Bullseye. Okay. So which one is not associated with erythema migrans? 1, 2, 3, or 4, or if you have another answer, share it with me. What do you think? 1? Raise your hands if you think 1. Okay. Does anyone think 1 is an erythema migrans? Jamie's like, yeah, Ellerin likes the trick questions. Right, so it is a trick question. That's right, they're all associated with erythema migrans. This is, so the last 3 are easy, but this is what we call a vesicular pustular variant of Lyme disease, and you should all Google it at some point because it's interesting. I don't see this a lot, but I do see it every summer. I see at least 1 case of this. And you guys may have seen, there's another form as well that's a little more hemorrhagic. Okay, it looks a little more hemorrhagic, okay? This is clearly not a classic case. This is definitely exception. When I first looked at, what if I said, is this loxoscelism? What is that? What's loxoscelism? Does anyone know the term? It's a special spider bite. Does anyone know what type of spider bite? Brown recluse, that's right. The brown recluse spider bite is loxoscelism. And this certainly looks something like that, but we don't really see brown recluse around here. Now, you guys maybe, does anyone want to comment on that? If I say we don't see, this is not really the geography where the brown recluse is endemic, do you agree with that? 100%. Okay. Have we ever seen a case? Has there ever been a? Yeah. Okay. We're trapped. People coming in. Got it. Okay. Okay. So how do I know this is Lyme disease? First of all, what was the serology of this patient? Lyme antibodies. What were they? Negative. They were negative. So how do I know this was Lyme disease? I brought this patient back a month later. I almost never do that, and I don't recommend it. unless you're in something like this where you want to, have it for a presentation. And I did serologies a month later, and he had converted. He had seroconverted, so, But most of the time, it doesn't matter. When you see something, in any of those other cases I presented, we shouldn't be ordering Lyme antibodies on case 2, 3, or 4, because it can't help us. If the Lyme antibody is negative, we need to treat. If the Lyme antibody is positive, we need to treat. If you order the Lyme antibody, there may be a provider that's seeing the patient that says, oh, the Lyme antibody is negative, I'm going to stop treatment. Now, you might say that's not good practice, but that is done in real life. There's no reason we need to do that. We want to commit. The EM rash is a clinical diagnosis. You say you think this is likely, we treat. If you're like, there's no way this is, then we don't treat. I have you guys may have heard me say this before, I have a very low threshold for giving doxycycline or amoxicillin in the summertime in New England when patients have a large circular, elliptical, bullseye, no bullseye, any rash like that's expanding. But I also never give the antibiotics when someone says I've got a little dime-sized rash after a tick bite, and maybe it even looks like a little bullseye or something, though that's not Lyme. That's from the saliva of the tick. That gives you just a reaction, okay? The saliva has enzymes and people react. So at the smaller end, you want it to be about 2 inches. You're looking at 5 centimeters at the small end. That's sort of the smallest range that we consider relevant. All right, good. 10-year-old female notes 2 to 3 months of aches and fatigue. No documented fevers, weight loss, labs are normal, inflammatory markers are normal. You do a Lyme antibody test and this is what you get. Okay? So the IgM is strongly positive, the IgG is negative. Okay, let's forget the IgA, I don't think it's relevant. Okay? IgM is strongly positive, the IgG is negative. Mom is there and wants to know, what do we do? What do you do? Treat? For what? What do we treat her? Early Lyme? Is this early Lyme? Yeah. So first of all, how many people have ever come into a scenario like this in your practice? Raise your hand if there's any time you've come into this scenario. Okay, so it's not rare, so you see this. Now let me ask you another question. Fine, so you treat. I've heard does anyone not treat this kid? Okay. What's the Western blot? The Western blot, you're right, okay. The Western blot is it's really not showing, the IgG immunoblot is really negative. It's not showing relevant bands and things. I know you see numbers there, but they're not relevant, the relevant bands. So the reading is significant levels of IgM and IgA antibody detected by the capture EIA, no IgG antibody detected. These results are compatible with recent early infection with B. burgdorferi. So you're not treating. Anyone else not treating? Just curious. Another one not treating. Okay, now for those of you who are treating, is the treatment, raise your hand if the treatment is going to make the kid better. Okay, no one's raising their hand, and someone's going like this. All right, good. Listen, I appreciate that. I do appreciate that. That's right, because this is really not consistent with early Lyme disease. Because we used to say if you have a persistent IgM more than 4 weeks later and no accompanying IgG, it is not consistent with Lyme disease. Alan Steer used to say that. Now we've moved a little bit to saying kind of 6 to 8 weeks. We've shifted a little bit, which I think is reasonable, by the way. I think shifting to 6 to 8 weeks. But if you're not seeing any relevant IgG antibody after a couple of months, and you're seeing a lone IgM, that is much more likely to be a false positive than a true positive. This is really important. Whether you're treating, I don't recommend treatment for these patients, but understand that there's pressures on us to do something. But at least it's important to know that this is unlikely Lyme disease, really unlikely. Like, I can't think of one case where I've seen no IgG after a couple of months, and the patient turned out to have bona fide Lyme disease. All right. I mean, listen, you can repeat it. It ain't gonna show IgG. No. Nope. It's not. If it were gonna show IgG, it would have been by now. Now, I'm not saying within the first couple of weeks. We could change this. This kid comes in the first couple of weeks, of course. Then we have to treat because it's all compatible. It could be the IgM alone. You know, so.
Do we understand what causes the low IgM?
The lone IgM?
The IgM that's positive.
Ah, yeah, oh, yeah, of course, yeah, sure. I mean, you know, IgMs in general, whether you're dealing with mycoplasma, whether you're dealing with really almost any IgM you can think about, HSV IgMs, they are uniformly unreliable. They're labile antibodies. You can have cross-reactivity from them. Other things can cross-react. Lots of non-specific things. It's not like it's necessarily a marker of one thing that you want to think about. It's just a non-specific and labile marker as opposed to the IgG, which tends to be more steady, a little more specific.
Would a persistent IgM make you want to investigate other tick-borne illnesses?
Not unless you're, you know, the question is, would the IgM persist? Would you want to think about other things like babesia or anaplasma or maybe other spirochetes, you know, syphilis, stuff like that? And the answer is really no. We have not seen this be a clue to other type of diseases. So questions about this? Yeah.
In deciding to not repeat it, though, you're assuming that this lab test has anything to do with the 2 to 3 month illness in the first place, as opposed to a coincidental finding of an early IgM in a kid that has something completely different going on.
Which when I see.
Yeah, all right, I'll get back up.
Oh, okay. When I see, that's right, when I see this in the kid, I'm thinking to myself, this kid's got something else going on.
Right. So what I'm saying is,
Yeah.
could this be, I mean, say she'd been sick in
Oh,
January, February, and March, and now you're seeing her in April. Could this be 2 weeks of early Lyme?
I see what you're saying.
Would you want to repeat it?
I mean, it's possible,
Now
but
she's in the
remember
backyard or
yeah,
something.
yeah, okay, that's fair enough. I mean, I guess it's possible.
I'm just curious.
Yeah.
I mean,
Yeah.
I think you don't know.
Yeah.
You can't assume it has anything.
But this is an illness, you know, I'd like to also see some history of that.
Yeah,
I'd like
like
to
a
see
rash
in
or
the
something.
past 2 weeks, the knees got more painful, they got a lymph node, and
Right.
suddenly the fevers became a little higher.
Right.
You know, I'd like to see some history. In this case, it was just, you know, fatigue and
Honest.
fatigue, yeah.
Yeah.
Yeah, okay, good. All right, now we're getting to the tough part. Post-Lyme syndrome. That's what I like to call this. I think this is real. I don't like to call it chronic Lyme disease because I don't believe that the spirochetes are actively replicating. Okay? One of the major reasons I don't think so is because I've seen thousands of these patients. Thousands. Many of you have referred these patients to me. And what I've never seen, ever, not once, is any of these patients at the point in time where I'm thinking post-Lyme syndrome, I never see an EM rash. I never see multiple EM rashes. I never see them develop a facial palsy. I've never seen them have carditis. I've never seen them develop Lyme arthritis at this stage. Radiculopathy. None of the features, if the spirochete were replicating, we'd expect to see some of these after treatment. And it never happens. So in my mind, the spirochete cannot be replicating. So I don't want to call it chronic Lyme. But something's going on. There's definitely something going on. What I don't know, and what I think, but certainly have no evidence to support this, is I think that this is a post-infectious syndrome that happens to be Lyme disease in some patients. It happens to be EBV in other patients. It can be the flu in another patient, parvovirus in this patient. There's lots of different things. We just happen to be in an era, it's more than a decade right now, where Lyme is kind of the go-to organism, right? 20 years ago was EBV, 30 years ago was Candida, and right now we're trying to attribute a lot of nonspecific symptoms to Lyme disease. Some of it, I do believe, is from Lyme that's leading to a post-infectious syndrome. Much of it is not, and we'll talk about that. So obviously there's controversy, we just talked about that. What are the major features? I think 3 buckets. Fatigue, 1 bucket. Arthralgias, myalgias, musculoskeletal, 2nd bucket. And the 3rd bucket is cognitive impairment. What do people like to call it? What do the patients call it? I don't know if the kids do.
Fog.
Brain fog, exactly. The fog. Yep. One of the questions is B. burgdorferi fully eradicated with recommended antibiotics, or is there persistent infection? A lot of the Lyme-designated specialists, self-designated specialists, think that you haven't eradicated the spirochete, so you need to continue the patients on antibiotics. Whereas, the Infectious Disease Society of America thinks that the B. burgdorferi has been eradicated. By the way, there's still an in-between. Like, it is possible that there's remnants. Studies have shown you can find remnants of the spirochete. Maybe the body is reacting to that. It's possible. But again, even if that were the case, I wouldn't call that chronic Lyme disease, because the spirochete is dead and you're just seeing remnants that perhaps our immune system is reacting to. I think that's plausible. So post-treatment Lyme disease syndrome, some have defined this as persistent subjective symptoms without objective symptoms that persist for at least 6 months after congenital therapy is completed. I think the 6 months, we get that a little bit from the chronic fatigue syndrome literature. It's not like 5 months, I don't think that they have a post-Lyme syndrome, or 4 months, but obviously we have to have definitions. We talked about bullet 2, with what some of the camps think. So a few things. Despite, 3rd bullet, despite lack of convincing evidence, advocates have been lobbying to have accepted Lyme disease treatment guidelines modified. Our society has been sued. They have been sued. This has gone into the court system. It's been a problem. And so let's talk about, what has Massachusetts done? What has the legislation recently done within the past year? Does anyone know? Despite Charlie Baker vetoing, despite my society saying we're being bullied right now, there's no evidence, scientific evidence to support this, what have the senators in the House of Representatives passed in Massachusetts? They passed a bill that says that insurers have to cover long-term antibiotics, months or years duration of antibiotics, for patients who are diagnosed with Lyme. Baker, to his credit, he basically said this is crazy. He's like, the science doesn't support this. Let's at least say, let's tweak the bill, and let's say, okay, if a specialist says this is symptoms from Lyme disease that are chronic or persistent or whatever, okay, then let's have the insurers back that. And I didn't say this, but part of the bill also says we have to cover experimental therapies, not just antibiotics, but experimental therapies. So he wanted to eliminate that part from the bill, but it got overruled. So it was passed. And I think, I can't remember, but I think the next time they're revisiting this is like 2020 or something, or 2021. So we're living with that for a while. That doesn't mean we have to prescribe it, but it puts pressure. It's an added pressure that's not scientifically validated. Okay, so, right. So it recently, yeah, you can see summer of last summer. That's when it went live. Okay, so categories of chronic Lyme disease. This is important. In category 1, there is no evidence. They're seronegative, and they're seronegative for Lyme. I do not believe that you can have I don't believe you can have a post-Lyme syndrome and be seronegative. Category 2, they do have symptoms and they have syndromes, but it's more compatible with another diagnosis. Okay, maybe the patient doesn't want to accept the diagnosis. It could be like MS, or occasionally I have patients with ALS that have seen me, or there's a kind of a chronic form of ALS that they want long-term treatment because they think this could be Lyme disease. You know, they're in a wheelchair, they're wheelchair bound, and they come in, and they really want to push. And maybe they've come to me because someone else has given them already one course of IV and they want another course. So, these patients don't look like they have Lyme disease. Category 3, patients don't have objective clinical evidence of Lyme, but they do have antibodies. Okay? And, you know, I will be the first one to say, if you call me about a patient that's seropositive, let's say they have an IgG, okay? You already have heard my kind of spiel on the IgM part. But if they have an IgG that's positive and you call me and like, should I treat or not, I'm pretty flexible, you know, because, I mean, frankly, Lyme is so controversial anyways. To sit with a Lyme IgG without treatment, you know, that could be problematic for you later on, for me later on. So I often say, okay, let's just give one course. Do I think it really helps them? No, I don't. I think most of these patients are not going to go on to develop Lyme arthritis, for example. But that conceivably you might say, where are they in their IgG? Here's a question. Untreated erythema migrans, documented erythema migrans, you don't treat it. What's the likelihood they'll go on to develop Lyme arthritis? Anyone know? It's high. It's high. It's like around 50% area from at least one study. Okay. Again, I don't know about the kids, adults, sort of which if that number is true for both populations, but it's high. It's much more likely than carditis, for instance. You know, AV block, things like that. So, you know, you could argue, all right, if they have an IgG, we don't really know where they are. Could they have had this a few months? You know, a few months before or a year before, by treating, maybe I'll stave off Lyme arthritis. I think it's possible, but most of the time my guess is that it's not helpful. And then category 4 is patients with symptoms associated with post-Lyme syndrome. Okay, so what's the likelihood of that? Well, in at least one prospective study, subjective symptoms were present 1 year or more in up to 13% of patients. You know, so we see this. I mean, if you look at 3 months later, studies show that, you know, 25% of patients can have ongoing symptoms, common. So these symptoms after Lyme are common. I mean, we see this all the time. It's not rare. So I think it's the category 4 that is sort of at least the one that we need to study the most. That's the one where we need to learn more about. What's causing this? What is it? You know, and Hopkins right now, amongst other centers, has a center looking at this, at category 4 specifically. They're trying to study these patients. So maybe we'll learn more about this. All right. Well, how do we know antibiotics don't work? How do we know? All right. So let's run through a few of the trials. Okay. The biggest one was Mark Klemner. He was actually the first, he was my mentor, my first mentor. Does anyone know Mark Klemner? Has anyone heard of him? He was the PI that was working on the needle. Remember the needle at BMC that was supposed to ultimately open up as like a biosafety level 4 lab? It's right by Boston Medical Center. That was his baby. And he never got to see it to fruition for different reasons. But in any event, he did a study that looked at, there were 129 patients, okay? So this is the biggest study. These patients all were diagnosed with Lyme disease. Some of them were seropositive, and they were seronegative group as well. These patients had documented EM, okay? So at both. He was looking at seronegative and seropositive, okay? They had to receive a full course of treatment for their initial. These patients, on average, had had symptoms for 4 years or so. That's important, because the critics of this study say, you know, this is crazy. You're treating patients for only 3 months. They've had symptoms for 3-4 years. This is you have to treat them much longer, okay? But and they were treated with 1 month of ceftriaxone IV and then 2 months of oral doxy. So they got 3 months of treatment. And in the end, there was no difference. So 40% of the patients in the ceftriaxone group improved by like quality of life indicators, you know, surveys and things. 40%. In the placebo group, 36% improved. So remember that. That's another thing that drives it. It's tough to figure this stuff out because at least a third, if not more, of the placebo group improves in these studies. So 40% improved in the ceftriaxone group, 36% improved in the placebo group, and then 33% or 32% worsened in the ceftriaxone group. You know, and there was 7%. Actually, not that study. There was a different. But in this study, there was between 1% and 2% life-threatening adverse events. Okay, meaning they had to be hospitalized, they had a Lyme infection, they had yeast in the blood, they had C. diff, whatever it was. Okay, so the conclusion of the study was this doesn't work. It doesn't work. Krupp et al. Looked at a smaller study, 56 patients. This one was ceftriaxone for 1 month. That was it. There was no orals after. What this showed was that basically they looked at 3 things. They wanted to look at fatigue overall, they want to look at neurocognitive symptoms, and they wanted to look at like CSF antigens in the CSF, so they did spinal taps to see. And what they basically showed was that at like 6 months, there was no difference in cognitive scores. There was no difference in the CSF markers or anything. There was less fatigue in the ceftriaxone group. One of the numbers was 22% reduction in fatigue in the ceftriaxone group, 9% in the placebo group. But there was 7% of patients had life-threatening reactions. That means they were hospitalized. 7% of these patients were hospitalized with, you know, serious Lyme-related complications, things like that. So, you know, and then when you looked at the fatigue actually, and they looked at the 6-month point, they looked at what the difference was in the fatigue, like how the intensity. They did another like fancy survey of looking at intensity of fatigue, and there was no statistically significant difference. So yeah, there was less fatigue in the ceftriaxone group, but it seemed like the differences were not really significant. Significant number, but intensity not really much different. Hard to look at this and say, let's stick lines in and things. All right, so let's see what else. Okay, let's look a little. These were look. These studies were done in like early 2000s and stuff. Okay.
What was the blinding issue?
Sorry. Yes. Thank you. Very important. Actually, maybe one of the most important things. 68% of the placebo group thought they were receiving ceftriaxone. Okay, so we think that there was a blinding, there were problems with the blinding mechanism. 68% of the patients who were receiving placebo thought they were receiving ceftriaxone. And 68% of the patients who were receiving ceftriaxone thought they were receiving ceftriaxone. So there were issues we think with the blinding of this. All right, now we're a little more up to date. Okay, 2016 New England Journal of Medicine. Randomized, double-blinded, placebo-controlled trial. This was Europe. Assigned patients that have persistent symptoms attributed to Lyme. They either had to have related temporally to proven Lyme disease or accompanied by an IgG or IgM immunoblot. Now listen, you might be saying, whoa, they allowed the IgM in as well. These are patients that probably don't have Lyme disease, or maybe it's false positive. Yeah, that's true, but you know what? It's real world practice, right? We raised our hands here. Many of us are treating these patients. So I think, I get it. I get why they designed it like this. So not everyone absolutely had Lyme, but many did. And this might be just sort of how we practice. They were randomized to 12 weeks of oral doxy, or 12 weeks of clarithromycin plus hydroxychloroquine. How many have used that? Right, because we don't have any Lyme designated specialists in the room. But if we did, this is a common practice that's used, or placebo, okay? All study groups received open label 2 weeks of IV ceftriaxone before randomization, okay? So even the placebo group did get IV therapy. Primary outcome was, again, you know, quality of life stuff, 36 health status, you know, how's your mental status, emotional status, physical activity, go through a list like this. 280 patients randomized. The summary score did not differ among the 3 groups. at the end of the therapy period. In all study groups, there was improvement, okay? 4 serious adverse events related to the study drug occurred during the first 2 weeks. They all got IV, remember that. There were no serious adverse events in the 12-week randomization. In the conclusion, the conclusion was it didn't help, right? There's no difference between the placebo and the other things, in the other groups. I mean, there was improvement, but it was like 36%. We already know from prior studies, even in the placebo, when you do, I mean, you could argue, well, the IV ceftriaxone is doing something. Patients are getting better, but there's no difference in that with the oral antibiotics on top of that. And we already know that in placebo groups where you don't give IV, you see a third of patients improve. So hard to get excited about this study. Okay, so what about attempts to find persistent infection with B. burgdorferi? Okay, some experimental studies in animal models, dogs, primates, mice, have found that you can get some DNA, persistent tissues after antimicrobial therapy. So you can. Now remember, if you amplify DNA or RNA, that does not equal active infection. We know after killed infection that you can still see DNA and RNA. That's one of the reasons why when we see patients with chlamydia, we say you can't test for it by molecular methods within 4 weeks because you expect it to be positive. C. diff, diarrhea is gone, you've treated them. If you check the C. diff PCR too early, you get positive results. Yet they're asymptomatic. So there's not necessarily a correlation between PCR and viable organisms. The relevance of animal models to human disease is unclear. And efforts to isolate, most importantly, efforts to isolate B. burgdorferi in patients with post-treatment Lyme disease syndrome have been unsuccessful. Yes?
Is it possible that the persistence of the DNA and RNA can cause an inflammatory reaction which is giving you the symptoms?
I think so. I think that's possible. I mean, inflammatory
Or
something.
immune modulating.
Immune modulating,
So
yeah.
almost like
Yeah.
a mild SIRS-like reaction giving you the same symptoms.
I think so. I think that's plausible. I do. Yeah. Xenodiagnosis. Ooh. Xenodiagnosis. I had to sort of teach myself about this. This is interesting. It detects vector-transmitted organisms by attaching natural vectors to potentially infected patient and examining the vector for the presence of organism after it is fed. Okay. All right, that's what xenodiagnosis is. How is it relevant? Well, we know that studies have shown that when Ixodes, when the deer tick attaches, that there's a substance in the saliva that causes the B. burgdorferi to migrate towards it. So not only is it not possibly giving you infection, but there's some type of chemoattractant. So they can use this for xenodiagnosis. All right, so here's the study, 2014, the Marks group. 36 patients evaluated for the presence of B. burgdorferi. All right, so follow this. Of the 36, 10 were seronegative healthy adults. Never had any Lyme. Okay, they were the controls. Okay? One was a potentially positive control who had an EM rash and had the tick placed at the same time antibiotics. So the tick is placed on the EM rash. Okay? And occlusive dressing put over it. Okay? Then there were 20 seropositive individuals, all right? 10 asymptomatic who had been treated for Lyme and who had high titers, and 10 patients who had post-treatment Lyme disease syndrome, okay? 5 patients completed antibiotics for treatment of erythema migrans 1 to 4 months early. Okay, so that's sort of it. So you get a lot of different smatterings of possibilities. Investigators placed 30 ticks, larval, right? The larval form, that's the first form. Right, that's the form before the nymph. They're tiny. Under retention dressing on each patient for 3 to 7 days.
How do they know those ticks have Lyme disease? Just because they're the larval ticks doesn't necessarily mean that they have.
They tested them, they made sure that they didn't have Lyme disease.
They did not.
They did not have Lyme disease, because they're looking for right. So these did not have Lyme disease. So the presence was looked for using cultures, using PCR techniques, and then other amplification techniques that I don't understand, okay? Authors were unable to recover any viable organisms, either from the ticks or from the skin biopsies or from any of the immunodeficient mice. There were some immunodeficient mice that they actually put on, so that then the tick they put on the mouse to see if even in immunodeficient mice, is there anything that we can give them. 2 patients had detectable B. burgdorferi by PCR, okay? 1 patient positive control early in the course, okay, that the positive control, okay, so it showed that right, I mean, that makes sense. I mean, you'd expect that. The other was from 1 patient. So 1 patient with post-treatment Lyme disease syndrome they did find detectable PCR, okay? And there were, how many were there that had PTLD? There were 10 of them. So 9 out of 10, nothing. 1 out of 10 did. You know, this needs further investigation, but certainly not the majority. So again, maybe this is food for thought, but it doesn't look like amplification is finding it. In 90% of the patients with PTLD could not amplify anything, all right? All right, so wrapping up, what do we do with this? First of all, has anyone seen this test before? Where is it from? Does anyone know where this test is from? IGeneX, have you heard of that? You've heard of that, right? IGeneX. Sorry. IGeneX. So, Mark Klempner did a study years ago looking at IGeneX. They had a urinary antigen for Lyme. And he basically sent random testing of healthy people, and then patients with Lyme disease, he just sent them random samples. He did a study on this. And he showed that they were like, you know, the number that were coming back positive were incredible. But in any event, here's the deal. IGeneX is a lab in Palo Alto that basically does testing. And they give you 2 interpretations. They give you IGeneX's interpretation based on internal validation studies. And then they give you CDC interpretations, okay? And it's clear that they have, well, how do I word this? The specificity of the CDC, there's no question that CDC is more specific. If you use CDC guidelines, it's more specific. But IGeneX would argue that their test is more sensitive, that you're going to find more Lyme disease that's going to be excluded by CDC. This is not FDA approved, but it does have a CLIA certification. So it's a certified lab, but it doesn't have FDA approval. So what's hard to find is these validation studies. You know, it's hard to see what it's based on. But this is causing lots of problems. You're going to see this. If you haven't seen this yet, you will. We're seeing more and more of these tests. And it's tricky because the patient says, I have Lyme disease. Look, I have this test. You're telling me I don't? It's a problem. You know, it's hard. I looked for data on this. I couldn't find, like, I need to look a little harder, actually. I couldn't find, I want to see clinical trials that are, or, you know, not a clinical trial, but I want to see, like, some type of study that compares this specific test with the CDC. But it is tricky, right? Because Lyme in itself, it's hard. I mean, what's the gold standard? Or are you going to say the gold standard is the CDC, right? They're not happy with that. IGeneX doesn't like that. So if prolonged antibiotics is not the answer, what is? And there's a big question mark here. Big question mark. So here I'm building, and then it's like flop. It doesn't feel good. You know? I don't know. Does anyone know what this is?
Spirituality.
It's a spiritual thing. Does anyone know specifically to our practice? This is the logo of what's that? What is that? The holy family practice. Yeah. So there are practices around us that are certainly deviating from CDC and Infectious Disease Society of America guidance. So that puts us in a tough place. Because patients are getting mixed messages. Obviously, if they were standing up here, they would think a lot of what I'm saying is probably too rigorous. It's not allowing flexibility, and so I think it would be nice at some point. I think what would be a good talk would be to get a point counterpoint. No yelling. We're not going to yell. We just want to hear what they have to say. Listen, here. If you want to read an interesting article, I want you to read an article by Ottwater, 2007, Clinical Infectious Diseases. Just look up Clinical Infectious Diseases, point counterpoint for Lyme disease. And it's Paul Ottwater does the point. He's from Hopkins. He's a great guy. And then there's another person that I don't know, but one of the Lyme designated specialists who does the counterpoint. And you can see, there's a lot of citations and there's a lot of differences in opinion. So I think it's a good article. I know it's a little outdated, but I think it's pretty relevant. So yeah, I'll stop there and take questions. Thanks. Yeah, thank you.
Do you think that there's any value in people in trying to create an expectation that treatment for migrants will cure their illness? That is, initially, I'm concerned that people come in thinking that a lot of people get chronic disease from this and don't believe that the treatment will fix their problem. It's like when you have a unsophisticated family who asks you, when will I know after this spinal tap if my child will walk again? And you go, God, it never occurred to me your child wouldn't walk after I do this spinal tap. Like, let's straighten that out before we get started. And when I treat kids for Lyme disease, I say to the people, that this course of treatment will fix this. And I'm just wondering how many people, whether anybody's tried to study, like, are people expecting to get chronically ill? And is that part of our problem?
It's interesting how to approach them. Listen, great point. Great point, great question. I think that, all I can say, I think sort of how we talk to our patients is critical, right? It is. How we set up if we say we're going to cure this with a 10-day course or 20-day course, and then they have symptoms after, it may set up a precedent. I think it's difficult to know exactly how to talk to them, and it's so hypercharged. It's tricky. I like to tell, what do I tell my patients? I tell my patients, look, the majority of patients do very well with treatment. There is a small percentage of patients that have persistent symptoms, but, it's less likely statistically, something kind of humdrum like that. Yeah.
I also think there may be a subgroup of patients that, and I'm not quite sure how to word this. I don't want to use the word enjoy, but I remember about 30 years ago, I had a baby that was perfectly healthy, 9 months old, something like that. Maybe had a yeast diaper rash once, and the mother came in, a few months after that and said, well, I did blah, blah, blah because of Matthew's condition. And I said, what condition? As far as I know, he didn't have a condition. She goes, well, the yeast that's all through his body. Yeah. And I said, I don't think he's got disseminated yeast infection. I think, I was trying to, I was trying not to be too sarcastic, actually. But, she really wanted him to have a condition.
Right.
And I wasn't buying into it, so shortly thereafter she found someone else who would, but...
So recently, a patient that was going for an IUD, they didn't come to me, but I heard the story, and the mother basically said, is it okay to place the IUD given her condition? And the condition was that she had chronic Lyme disease. So you're right. This is real.
We're pediatricians, so is the parent, or is there some set of adults who would be that parent if they had kids, or? But I think it would be very interesting to do, in the context of all of how is this impacting your life, maybe even some personality correlations to see if anything interesting.
You know,
pops up.
one thing I didn't say, and I meant to say this, I should have, but back to this Klempner study. Klempner study, 129 patients. How many patients had to be screened to get to that number? Take a guess. Take a guess. And how thousands? 5,000, over 5,000 patients were screened to get to that number. 40% of them who had the, came in, they were looking for patients, by the way, right? You're sending out a survey, we're looking for patients with kind of post-Lyme syndrome. 40% of them never had any inkling of Lyme. It took 4 years for them to recruit down to that study. Yeah.
Do you have a recommendation? I have a lot of families that have been asking me lately, what's the best prevention? Last year I had my yard sprayed and the kids never came in with ticks. And my feeling is in my yard, not far from here, the deer walk through my yard at least several times a week. I don't think spraying the yard does it. And then what kind of chemicals, they ask me, would be reasonable? Do they use the eucalyptus oil? Do they use
I would just follow the guidelines that have the DEET and they have the different recommendations, but yeah.
Spraying the yard,
Yeah.
I don't think is necessarily something reasonable. But
Yeah, spraying the yard,
So you can use
Mark?
the same similar precautions like you would for malaria prophylaxis or that sort of stuff. So you can use DEET on the skin. You can actually get permethrin.
Yeah, I'm just
But for
asking.
yards, so you can actually plant chrysanthemum because permethrin actually is a synthetic derivative of chrysanthemum. That's a natural insecticide.
That's cool. That's cool.
So that's some way that if they're very against spraying and all that stuff, some of the herbal stuff that would actually help.
Do you think spirochete replication is self-limited? So if somebody had sort of a subclinical or a misdiagnosis of Lyme and was never treated, they developed a post-Lyme syndrome, that they wouldn't have active Lyme disease at the same time? Or is it
I know what you're
something
saying.
They would treat much, much later?
these would be the
But they were never treated
IgGs.
in
These would be the
first place.
IgGs that come in with symptoms, right? And
Never
IgG would never
treated
had,
in the
yeah,
first place.
yeah. I mean,
And how does it compare to tertiary syphilis?
it's hard to know, right? Hard to know. What's the gold standard? I mean, it's
But do you think the spirochetes would be still replicable?
no, still replicating?
Yeah.
I don't. That's the whole point about the IgG. When the IgG that comes to you, your practice, who's asymptomatic, I think it's controversial about treatment, but I think most of those patients, if you didn't treat them, wouldn't go on to develop the question is, are they going to develop a rash? Right? They're not going to develop.
The cognitive symptoms
Yeah.
years later
Yeah.
because they were never treated.
Yeah.
But because the scenarios that you were presenting had to do with post-treatment
Yeah.
Lyme syndrome.
Let me see if I can get data on that. I think there's some data on that, but I think the answer is it's not a high likelihood that they present like that. But let me see if I can get you data. Yes.
So Todd, one of the big battles we're fighting is parents who are asking for prophylaxis, either in younger kids who are less than that 8-year-old,
Yeah.
maybe take doxy,
Yeah.
or for folks who have these tick bites where very clearly the tick was attached for a very short duration,
Yeah.
less than 24 hours.
Yeah.
And again, we're having issues that there are other places that are putting kids on, 10-day courses, 14-day courses, 21-day courses.
Stop the madness. So this is what I say. First of all, the tick, remember, the spirochete's living in the midgut. It cannot transmit Lyme. It has to regurgitate it up into the salivary glands. It takes time. 24 hours, no way. 36 hours, which is what the guidelines say, is conservative. That's conservative, okay? Most of the studies show that in less than 72 hours of attachment, there have been studies that show there have been 0 cases of transmission. Okay. I mean, the little kids, remember, when you look at the Westchester study, granted it was adults, but I mean, when you look at the Westchester study, I mean, in the placebo group, and this is a hyperendemic area, 3.4% of patients develop Lyme disease. 3.4%. So let's call it 96. 96% of the adults did not develop Lyme disease. So 96% didn't need treatment. 4% did. How would you treat those 4% who develop it? You treat them with a couple of weeks or something, 10 days, 14 days of doxycycline or 14 days of amoxicillin, okay? So why, after a tick bite, would you treat with just because a child can't get doxycycline, why would you treat them with amoxicillin, which hasn't been proven? But why would you treat them with 10 days or 14 days of amoxicillin prophylactically, when there's only a 4% chance that ultimately you'll have to treat them with the same amount later? That does, convince me of that.
Is it not?
Because we're so scared, of, huh? Because of hysteria.
It's a hysteria.
It's hysteria.
But the study showed that treating
Treating-
a dose of doxy.
Got it from 3.4% to 0.4%.
So the idea would be to do that. I mean, a single dose of doxy, even in a kid less than 8 years of age, isn't going to stain the teeth.
Fine.
So
Okay.
you could
If
do
that's
that,
the
as long
case,
as you talk to the family.
What's the
and
dose?
say-
What's the dose? You just do weight based. Like, what would, it's 200 adults. So what would it be? Weight based. Whatever the weight based is. You know, listen. If you don't have a problem with a single dose, I don't have a problem with it. I mean, 40% of the adults got sick with in the trial, but you'll probably just have an upset kid for 24 hours.
I'm from the Cape.
Yeah.
And the Nantucket Islands.
Yeah.
We have practice out in Kentucky. Our incidence of Lyme is much higher than it was in the Westchester study. So I would think that would encourage some prophylaxis, especially since you've spent an hour telling us about the potential of this post-Lyme syndrome. So we have to jump ahead and stop the infections if it's at all possible, so we don't get into this quagmire.
Yeah.
Of this.
So let's study it. This is a pretty easy study. This isn't like an expensive study
Going on now.
with the kids. With kids.
I mean, I think that would be a perfect study.
I think we should study something. Let's do, I don't know. They have done some amoxicillin. They have done some short course amoxicillin, I believe, that hasn't worked. But I need to look at that as well. Let's study this.
Pros.
Huh?
That's an idea for pros. Pro studies that get involved with pediatric groups.
What's it called? What's this?
You've never heard of the pro?
Pediatric research in the office setting. It's the American Academy of Pediatrics.
Great. I think it's a good study. I do. But let's study it. As opposed to being hysterical about it and saying let's treat for a full course for such a small percentage. It just seems like the risk-benefit ratio to me doesn't seem it's not following. It doesn't make sense to me. Yes.
I couldn't hear the question before from the front, so I hope this isn't a repeat question. But what do you do with, this happens on occasion, if somebody's comes in and you know that they've had Lyme disease in the past, they've been diagnosed with Lyme disease, and 2 years later they come back and they feel they have a recurrence of symptoms, and they want you to test, and then you test and you find IgG. What's the range of time that we should expect that IgG
To dissipate?
to still be there? Is it protective at all? And what do we do then with the people who come in with those symptoms?
Great question. These are good questions. So I believe that if you have Lyme arthritis, you are not getting Lyme disease ever again. Okay. Now I don't know if every person would tell you the same thing, but I do believe it. People are kind of hesitant to say you're immune from Lyme. I do believe stage 3 Lyme, if you're in stage 3 Lyme, if you have a fully developed Western blot with IgG, which the kids have when they have Lyme arthritis, I believe you'll never see Lyme again. I'd love someone to tell me any case that you've seen where that proves wrong. In the absence of that, it's clear that erythema migrans is not protective. There's a 10%, 15% chance of getting recurrent lesions again. I thought stage 2 might be protective. I think it is, but I think I've seen stage 2 disease. Someone come in with documented Lyme after. I think it's uncommon, but can happen. So I'd say stage 3 to me is you're immune. Stage 1 clearly can get it again. And I'd say stage 2 is a little bit of a gray area. So I don't know if that helps.
But then you test kids.
Yeah,
They've had stage 1 or stage 2.
Yeah.
And then 2 years later, they come in because they've had.
And their antibodies look the same?
They've had 4 weeks of fatigue and joint pains and
I know.
this and that.
And
And the IgG is positive.
As it was before, or no?
Well, maybe that's
Yeah.
tested.
Listen, tough to say. Tough to say. But listen, but every summer, what about the kid who every summer, the adult every summer who's getting Lyme disease with no symptoms? I mean, not no symptoms, but no EM rash, no facial palsies. I mean, that to me is just incredulous. You know?
I guess there's no, like nowadays, there's no great perfect answer.
There's no perfect answer there. But I will tell you, if you repeat the antibody test, you expect it to be, the IgG persists. You don't expect seroreversion. Now, any time that you check, compare serotypes and stuff, there's always going to be, one serotype that's a little different. I mean, there's just the variation, the natural variation. But for the most part, it looks the same. It looks the same. You're not, and IgM the same way. The IgM can persist for years. So persistent IgM does not mean that this is early disease, early infection. That's why you can only interpret, key point, I've said it in the beginning, I'm going to say it in the end. The IgM you can only interpret within the first 1 to 2 months of disease, of illness, of symptoms. If it's after that, you want to throw the IgM out of your mind. It can only mislead you.
Do you have any updated statistics on odds of rash-free stage 1 and then treatment of the summer guidelines, like the child or adult with a fever in the summer, without other sore throat, diarrhea, cough?
It's tough. Yeah, when you look at the literature, the presence of an EM rash, I've seen anywhere from 40% to 80%. Most recently, it seems like it's more than 50%, but yeah, look here, that's the other problem is what's the gold standard of that? What's the gold standard? I mean, you have a painless rash on your popliteal fossa that's going to go away anyways. I mean, I don't trust, whatever the studies are, it probably is, I think the rash is probably there more commonly, but it's just missed a lot of the times. But it's clear that you can have rashless stage 1, whether it's missed or just not there. There's no question that you don't need the EM rash to be in stage 1. But it certainly helps, the diagnosis.
I don't know what other people do, but you just give people 2 weeks of doxy.
Same.
Something.
Same.
You don't have another reason to.
Yeah, same. Summertime, so I have a low threshold to give patients who come in the summertime with aches, low-grade fevers, and absence of diarrhea, absence of vomiting, absence of cough. If they're absent that and they have unexplained stuff, I have a very low threshold to give them doxing. And once a summer, I get burned by someone who's got some GI stuff, and I'm like, this is just something, and then they come back, 10 days later, 2 weeks later, they come back with like a facial palsy. And my gut is that I missed the stage 1, Do I have to go? Is that it? Last question, or do we have time for one more question?
What's the status of the vaccine?
The vaccine, unfortunately, you probably heard, I actually worked on the Lyme vaccine with Klempner. So we worked on, not the one that got approved. The Steers was the one who got approved. I worked on the Connaught one. It was approved, okay? It was approved in like 99. It got pulled in like 2001. It was not long lasting. The bottom line was you needed 3 shots, and then you needed a booster before every season, so like springtime in every season. So number 1, it was bulky. Number 2 was that it didn't sell. Because Lyme disease, even though we're interested in this group, you can imagine if you're in Iowa, you're not interested in this stuff. If you're in, it's only, right, if you're not in New England or Minnesota or Wisconsin or maybe little pockets of California, you're not interested in this. So it's not like this seller, like an antihypertensive medication or the flu vaccine. So it didn't sell. And then there were these questionable cases of arthritis that was occurring after patients got the vaccine. Not necessarily Lyme arthritis, but there was a question of whether autoimmunity could be, I don't think that was ever proven, but it was enough for GSK to say, we're done, and they pulled it. So, they weren't making money. The pharmaceutical company was not making money with this vaccine. Got pulled. Yeah. Thanks, guys. Thank you.